patient experience near syncope events and no structural heart disease and otherwise unremarkable findings. So here is our EKG during the VT. Actually, I couldn't find his real EKG, and I found only this. I found only this EKG from his EGM. So as we see here, that okay to see. Okay, as we see here, this is a wide complex tachycardia and a right bundle branch pattern and the inferior axis. And left axis deviation is like more than minus 90 degrees, and V1 is showing a RSR configuration. So from here we can see that this is more likely a fascicular VT. So here we can see that the QRS is wide is like around 160 millisecond. So the baseline sinus rhythm of the patient, and we cannot see any other abnormal findings. So we have tried to induce from the right atrial side, and but as you see here, we cannot find we cannot induce the VT from the right atrial side. So next, we have had made the induction from the right ventricular pacing, and here is the VT have had induced, and we can see there is as you see here, here is his catheter placed and the right ventricular catheters, and this is the actual catheters. And his when the his have is buried in the ventricular potential. Here is his and the V and the ventricular potential. The ventricle is started from here, so it's much earlier compared to our his and the other ventricular EGMs. So how it happened? So it's like ventricle impulse is going through the left posterior fascicle up to the his area, and from the his it reaches the AV node and back to the right bundle. So that's why our his and the right-sided catheters ventricle is buried in our ventricular in the whole V. So HV is a very short and buried in the ventricular potentials. So we have tried to check whether it's a well, actually for the fascicular VT we have had this we had to distinguish whether it's a local VT or it's a reentry VT reentry. So to distinguish this one, we need to make a pace mapping from the right ventricular side, from the left ventricular side. So from the right ventricular side, as you see here during our VT pace mapping, and here is our VT continues. So right ventricular change do not change the VT morphology. So it's like a most likely it's a reentry VT. So we have had and we have had found that we induced our VT, and we found out that our HV interval is very short in our VT. And also we found that the right ventricular pacing do not change the VT morphology. So we had to go to left side. And we inserted our catheters in the left side, and we insert our catheters into that side. And as you see here, right here, this is his catheters. Yeah, and this is his catheters, and this is the our RV catheters, and those are the left ventricular catheters. We put the duodeca catheter into our left ventricle by the aortic valve, transaortic approach, and we have had started mapping. So during our like that one. So during our VT, we have during our VT, you can clearly see here is a fascicular potential, before our V ventricular potential. So here is his, and here is V. So our fascicular potential is much earlier than his potential. So this is like a very unique EGM morphology during the fascicular VT. So I think that this is important thing. So next, in a fascicular VT, the most important part is to find the diastolic potential during the VT and during the sinus rhythm. So why it's this important, I will explain later. But now here I want to show our potentials. So before the during the and this is a very famous paper by the Dr. Oh, I forgot. Okay, from the Japanese doctors, and they said like during the sinus rhythm, diastolic potential is a very slow potential, and is during the sinus rhythm is coming out after the V. And A, his, and left posterior fascicular potential, and V, and the diastolic potential. But during the ventricular tachycardia, diastolic potential is like coming out before our fascicular potential. So this is like we have to find out this diastolic potential and this left posterior fascicular potential showed here. So this is I thought that this is my diastolic potential, and this is our fascicular potential, more prominent and more closer to the ventricular potentials. And here is our his potentials. So there is like two potential from the left ventricular side. Yeah, here, and although it's a very little, you can see here there is a potential here and here. So we thought that this is our diastolic potential, and we call it P1 potential. So here during the sinus rhythm, we can clearly see this is our fascicular potential. Yeah, very close to the ventricular side, and it's after the his potential. And here is also one potential. You can clearly see this one is as a potential. And this is our diastolic potential, and we call it P1 potential. This is our late potential, which is showing that this is our target for the ablation point. So here is our potential again, and we can clearly see now the more bigger, more clear the diastolic potential. So we have had entrant from the left ventricular side during the ventricular tachycardia. And as you see here, the EKG morphology almost same. And also there's a VT entrainment from left ventricular side is less than 30 milliseconds. So it says like we are in the reentry circuit. We are somewhere within the reentry circuit. So we are very close to our ablation site. So as we know that from the ablation catheter, we can insert from the transaortic approach, but still it's a ablation catheter cannot reach the mapping site, cannot reach the ablation site clearly, and it will move again by the heart movement. And so that's why we have had the doctors have had like a suggested more stable site from the transeptal approach. So we made a transeptal approach, and as you see here is our ablation catheter is making a V curve and coming out into left ventricular septal side is here. And here is our left ventricular mapping catheter is placed. So on the ablation catheter, here is our ablation catheter, and now in the ablation catheter, we can clearly see our potential, late potential, diastolic potential. It's a P1 potential, and here is our fascicular potential. So we had, so we did the ablation at this point, and we have had a very good results. And after the ablation potential and after the ablation, we couldn't induce the VT anymore. And the patient is now, after the ablation procedure, is almost 2 years, and the patient do not have any VT episodes again. So I was looking for the left vesicular mapping, very good papers for the trainings, and also for our other fellows in our hospital and the young doctors. And I was looking, and finally I found a very nice paper from the Dr. Marchinsky. He have had this presentation in the European Society of Cardiology in 2024. I think that this is a very brilliant paper, brilliant presentation. So that's why I have had a took his presentation, copied his presentation and attached it to mine. As you see here, corvid is a very common form is left posterior fascicle, and this is a more than 90%. And it have a right bundle branch block pattern with the superior axis, and the other uncommon fascicular VTs are left anterior fascicle, and it has a right bundle branch block and right anterior right axis deviation, and it's around 8%. And more uncommon form is like a left septal fascicular VT with the narrow QRS and dissociated A and V with adenosine and short HV. So, and the substrate and mechanism for idiopathic left ventricular fascicular VT is like a slow conduction, delayed potentials. So as you see here, this is the Dr. Nagami's Dr. Nagami's paper, and here, as I showed you earlier, it said like a diastolic potential is here, and during the sinus rhythm, because our heart is impulse is propagates from the left atrium, so from the base side left ventricle have an impulse. So from the base, the impulse is going through the left posterior fascicle, and it reaches exit side, and still it goes to the apex. So our diastolic potential is much more slower than the left posterior fascicular impulse propagation, and is like a slowing down, and it do not initiate the VT. But still, if there is a VT, our left posterior fascicle and the diastolic potential is going by this reentry. So the EP substrate for the left vesicular VT is diastolic but delayed potential in sinus rhythm after the QRS, and it's very calcium dependent. And during VT, retrograde Purkinje potentials in the region of slow conduction. This is our region of slow conduction. And the VT mechanism is like a macro reentrant VT of very huge size. So the doctors have had the challenge themselves whether the VT circuit is, how big is the VT circuit. And here in Dr. Wen have had find out that around the mean of the 3.1 centimeter macroentrant circuit. Here is here is our successful ablation site, and here is our earliest ventricular site. So this is like an exit site, and this is our successful ablation site. Between them is like more than 3 centimeters. So our VT site, reentry circuit is very big. So to make a successful ablation, it's better to find the P1 potential and P2, P1 and P2 potential. It will be much more easier to ablate them with these two potential. Sometimes we are like failing to find the P1 potential. In that time, we just make a line through the septum. But still, there is a high risk of the recurrence of the VT. So better to find the P1 potential. So here the Dr. Marchlinsky has suggested how to ablate the fascicular VT in left ventricular ablation. So as we said earlier, that the typical mechanism is like a reentry with relatively large circuit that includes calcium dependence fiber anatomical linked to Purkinje network, and is verapamil responsive, rare focal automatic VT. So in the beginning, I said like we have to distinguish whether our VT is local, focal, or it's a reentry. So here he have had highlighted that we have to distinguish before the mapping whether the mechanism is VT mechanism is a reentry or focal. So before going to left ventricle, confirm inducible VT and EKG morphology characteristic consistent with fascicular VT, short HV, distal to proximal His activation. So this is a very important part. And the confirm VT mechanism, pace from the right ventricular apex in sinus rhythm and document paced QRS, entrain VT from the right ventricle and confirm pacing with fusion, can also document progressive fusion and further confirm reentrant mechanism. So look out for the focal testing and whether to distinguish whether it's a focal VT or it's a reentry. So match the QRS morphology during VT that RE pacing and during the sinus rhythm. So here next, the ablation of ventricular tachycardia, ablation of fascicular tachycardia. So as we said, locations and post and posterior and anterior fascicles. Most common in inferior for the left posterior fascicular VT, most common ablation site is the inferior septum. As you see here, it's the inferior septum, mid to apical septum, and right ventricular base, left ventricular base. So for the right bundle branch, right inferior axis deviation VT, we have to make a more anterior and basal free wall ablation. So how to map? So this is a very important part, and the activation mapping to identify earliest Purkinje potential, as we showed you before, and the pace mapping to identify the exit site. So we have showed that we have had paced from the left ventricular distal electrodes, and our pacing site matched the VT. So it's actually we are distinguishing our exit site. Where is our exit site of the left ventricle? So, but still exit site is a good collaborative data. So here is it's a very this is from the Nogami, and he have compared the successful ablation site and the unsuccessful ablation site. So as we see here, he also had a P potential here. And the P potential and V potential is like already is like fused with each other. So here, if our EGM is look like this one, and he have suggested that this is a very unsuccessful ablation site. But the successful ablation site is the P potential is more clearly is separated from our ventricular potentials. So this is much more a successful ablation site. So our target is to find like this configuration. So we will be more successful then. So here is like it's our exit site, yeah. So well, we need to ablate here. We need to ablate here, and that would be our successful site. And if we fail, we can go to our exit site and make a linear ablation here. So, but still, this have like a recurrency rate. So it's and here he have had continued to explain about those potentials on the EGM and the 3D mapping. As we see here, there is during the sinus rhythm, and our fascicular potentials is here, and our diastolic potentials is showing here. So here our diastolic potential site is here. So and the diastolic potential site is here, and here, and during the VT, our diastolic potentials is much more pre-excited and earlier, and here is our diastolic potential site. So this is the much more successful ablation site compared to those areas. So here is the final final part of this vascular VT ablation case. And as I said, like a typical mechanism is the reentry and with the very large circuit, and 90% involved in the left posterior fascicle, and around 8% involved left anterior fascicle, and less than 2% is left upper septal fascicle. And also we have to induce the VT and distinguish whether it's a focal mechanism or the reentry mechanism. So next, when you go into the left ventricular side, we have to find the Purkinje potential and the delayed potentials during the sinus rhythm, and to find the train the VT, and to find whether our VT during the VT and our pace mapping is a good match. So I have tried to draw by myself this one, and I'm sorry it's not good enough. And our ablation site is like the area where there's a P1 potential is a very good distinguished. So, and exit site is also good, but still the P1 potential is much more helpful than the others. Yeah, thank you. Thank you very much. Do you hear me, or I was talking alone?
We heard very well. Excellent presentation and a very nice case and a comprehensive review. Thank you very much. So let's discuss regarding your case first. Dr. Huang? Where is he? Okay, let's take a question from the audience. Dr. Huang will start first.
Dr. Sarul, can you hear me?
Yes.
Thank you for your nice presentation. And congratulations on your successful ablation.
Thank you.
Yeah, before procedure, did you confirm the verapamil sensitivity?
No, we have had confirmed the adenosine sensitivity. The patient was on the verapamil, and although the verapamil was reducing his palpitation recurrence rate, but still he had a vesicular VT, so we decided to take him to the EP lab.
The question is, how about inducibility by atrial pacing?
Well, we have tried to induce from the right atrial side, but our right atrial side inducibility was not successful. But the right ventricular side, the inducibility was good, so we proceeded with the right ventricular inducibility, and later we proceeded with the left ventricular inducibility.
Never induced by atrial pacing.
Well, a few times we have tried to induce from the right atrial side, and later we stopped trying that one because the other side was easily induced by from the other side we could easily induce. But still, yes, there is every paper said the vesicular VT induces by the right atrial side, and we have had 10 patients with the vesicular VT, and many of them had a good inducibility from the right atrial side, and this patient, I couldn't induce him from the right atrial side. Yeah.
I think during the tachycardia, we can try to entrainment pacing from CS coronary sinus.
Yes.
Very helpful for confirm re-entry tachycardia.
Yeah.
Okay, thank you.
Can you explain us what's the finding of CS entrainment pacing during ongoing vascular VT?
If we perform the CS entrainment pacing, you can pace the CS from various cycle length. So you
Mhm.
can confirm the fixed fusion and
Mhm.
progressive fusion. CS is far from the reentry circuit, so we can confirm the progressive fusion from the CS pacing.
Yeah.
Okay, Saru, the excellent case. How did you differentiate the papillary muscle VT in this case?
Well, I thought that the papillary muscle VT and the fascicular VT have a different configuration. At least the R is much wider than compared to the fascicular VT. But if it's have had a mixed like a fascicular VT with the papillary muscle VT, yeah, it can be narrow. So, but still, I don't believe that this was a fascicular. No, this was a papillary muscle VT. It clearly showed around the no, higher than the papillary muscle.
Yes, if you can induce the VT reproducibly by programmed stimulation, it is reentrant mechanism and more likely to be the vascular VT. But there was the circulation paper published by Komachi and Nogami. They reported the combination of vascular VT reentry around the papillary muscle, as you mentioned. So we need to try to differentiate it. Generally speaking, can you see the VT ECG, 12-lead ECG you showed? Yeah, generally if there is a small Q wave and wide pulse complex in V1, favors Hepler muscle VT, and the absence of a small Q wave in AVL favors a Hepler muscle VT. However, it is not the absolute criteria. So it is not 100% sure to differentiate papillary muscle VT and vascular VT based on the 12-lead ECG, but your patient shows both the characteristics based on the ECG. So, Sarah, there are many vascular VT patient in Mongolia, right?
Yes.
So
And
compare.
one more is coming. One
What?
more is coming. We have
more is
had prepared. We have had prepared also 14 years old boy for the next week. So he's
That's good
also.
for you. So I wonder Dr. Chen Huang is still there. Can you hear me, Dr. Huang?
I can hear you.
Okay.
All right.
Dr.
Taro.
Huang, so last time we discussed about the mechanism of vascular VT and
Mhm.
why there's many patients of vascular VT in Mongolia and Southeast Asia and India. And could you please your hypothesis regarding the mechanism of vascular VT?
Before we go there, let's discuss this case first.
Okay.
Saro,
Yes.
why did you say this is a posterior fascicular VT? You show the example of in this slide, why the complex tachycardia right bundle and inferior axis and all that. And then your clinical ECG of tachycardia. Look at the lead one. What do you think about lead one? Your clinical patient.
I think that the very narrow R wave.
Yes.
So I think that this is conducted by the conduction system.
How about your example of why the complex tachycardia is shown in the tracing? Lead one. What does that look like? They're positive or negative, lead one?
Yeah, it's a positive and negative.
No, but how about the
Huh?
example tachycardia you're showing to us?
This
No.
one?
Yeah, this one. Look at I'm talking why the complex tachycardia right bundle branch block, and then you put a reference ECG, I assume. What is that reference ECG? In a small box, inside the box.
Yeah. This one.
This one, what is this is from? Is this a fascicular VT example that you're showing us? What is this?
Well, this is more like a fascicular VT ECG. Yeah.
How about your patient?
My patient. I don't understand your question. Yeah. I'm
Lead
sorry.
one of
And the lead 3 is like it's a converted. Yeah,
okay.
I
You
understand.
measure also QRS complex during your case, right?
Yep.
164, if I remember correct.
Huh?
Your QRS patient, QRS was
164. Yeah, 164.
Is
Yes, you're right.
that expected in fascicular VT? What is the typical duration of fascicular VT, Sarvo?
It's like from the 140 to 160 state.
What?
100, no, it's 120 until the 160.
Typically, you would expect to see less than bundle branch block, right?
Yes.
That mean has to
That
be less
mean
than what?
might be mixed with the papillary muscles.
Your patient QRS is too wide
Yes.
to say this is a fascicular VT.
Yeah.
That's number one. Okay.
Yeah.
Number two, your axis is not typical posterior fascicular VT.
Yes.
Okay.
It has.
Little bit more posterior than anticipated. You can see your example right under your screen. So this is something that troubles me a little bit. And also, if you look at your intracardiac signal, go to the intracardiac signal. Okay. So you induce a tachycardia, right?
Yes.
Can you look carefully? What do you see in the right ventricle proximal signal? What do you see? Right ventricle proximal. Yes, that's spiky. Small spike. Is that the right bundle?
Yeah, I think it's the right bundle signal.
Right bundle.
Yeah.
Look at the timing with his bundle. They're about the same.
No, it's a little earlier, I believe so.
Right bundle.
Or maybe it is all same.
Same.
Yeah.
So your diagram you're showing to me on your small box in your bottom corner, your diagram, your schematic diagram of VT, this P1, P2 business.
Yeah. No,
Doesn't
I
make
just
sense.
wanted to show like this impulse is going like that way and going downward
correct.
this way.
I understand that, but your intention is clear. I understand that, but your EGM doesn't explain what you're trying to explain to me.
Uh-huh.
How can you right bundle? His can activate at the same time. That means focus is what? Same physical
Almost same in
thickness
the left, almost same with the left ventricular side.
is more towards the septum posterior papillary muscle area, maybe. That give you same activation, transseptal activation through the septum because of papillary muscle. And then your his bundle, right bundle activation time is about the same. So there's many feature in your case here is that I am not sure this is a fascicular VT. Okay, let's go over, keep going. Go there, you find the ablation EGM there. Okay, right there. No, go back there. VT, no VT, one more. Okay. Go to the next one. Okay. Go to the next one. Yeah, right there. If you look carefully, the very first complex, you nicely point out LV34 channel, small potential. How do you cope with the LV channel 1, 2? There's another potential even earlier than that. Go to the LV1, 2. Yeah, go to the first beat. You can see even better. Yeah, right there. So then how will you argue that your focus is much lower than what you're pointing to us? It is. Your focus is further down, not in the way you are thinking. So even though your catheter placement was good, I think, and then you have that, but at one point that I want you to make, show me your LA of your catheter placement. Is for teaching forever. Yeah, look at this catheter. If you look at the in LA view, this catheter is not hugging the septum. It's going down to the posterior papillary muscle. In LA view, your distal tip has to curve toward the right side septum. That would be typical posterior fascicular potential recording site. This what you see is going straight down to the aortic valve toward the motor of the papillary muscle. So I'm assuming that I am not sure what we are looking at it, but that I think also explains why your EGM signal is unstable, varying a little bit. So next time when you want to really record the posterior fascicular potential nicely in LA view, your distal tip have to curve toward the right ventricular catheter. Okay?
Okay.
All right. Go to the next slide now. Go to ablation. How's that? You try to ablate this thing right now. You're pointing something in arrow that you think that's a P1 in sinus.
Well, actually, I think it's just this. How to say garbage.
No, not that
I-
one. No, I'm talking about, no, I want to show you something. I'm here to teach you. I'm not trying to criticize you. That signal you're pointing. What do you
Yeah.
think about signal?
Well, it has to be more sharper.
Yes, it's a
Yeah.
low frequency,
Yeah.
okay? And then they are wide.
And it's
Okay.
far. It's a little far.
No, I'm going to talk to you something. What do you think that is happening that particular timing? Draw the line to the T wave from there. T wave all the way up, straight up. It's the onset of a T wave. What
Yeah.
happening onset of a T wave in your heart?
Diastole.
Diastole or systole? QRS complex, squeeze, then what happened?
Squeeze and relax.
Yeah, it's a valve is wide open.
Yeah.
Okay?
Yeah.
So
You mean it might be valvular.
it's a cordis or subvalvular structures. Okay? It's not
Okay.
electric signal that you're looking at it. Okay?
Okay.
So because the left ventricle in young male patient or normal heart, it's very small cavity during the systole. Okay?
Uh-huh.
Therefore, your catheter subject to record many mechanical noisy.
Oh, yeah.
Particularly around the papillary muscle, you will have a contraction of a papillary muscle, cordis, and so on. So that is even more distinctively possible. Go to the ablation signal. Your
Yeah,
ablation
ablation signal was much more beautiful and bigger. Yeah, here.
right here. And then I want you to stay there. Look at the mitral valve, LV34, channel 34. What do you see?
Yeah, those signals again.
Oh, there's a two signal there. Go to
Yeah,
next.
one and
Now go to next signal. Yeah, right there. 1 and 2.
Mm.
Opening and closing mitral valve far field signal. What is that signal, biggest signal showing to you? Do you know what that is?
it's
Is a papillary muscle contractions artifact. Okay?
okay.
That's what you see. So that would not be typical fascicular potential or P1 that people refer to. They tended to happen very close to the intracavitary LV signal. And I regret that you haven't done one thing for me. If you're thinking this is a reentrant tachycardia by deductive pacing maneuver from the RV, which is subject to many errors. So if you're really thinking about this fascicular VT was, I would paste and train from LV1, LV2, LV3, LV4, LV5 to prove that the posterior fascicle indeed is part of tachycardia. Yeah, you got beautiful posterior fascicular potential there, proximal. And then during the VT, you should paste from there so whether you can entrain this thing. That would be ultimate proof this is a reentry. You haven't proven to me this is a reentry yet. I'm very skeptical still. So next time for your future cases, if you cannot induce A-pacing, RV pacing, if you have documented the clinical VT of a fascicular VT, put the catheter down to the posterior fascicle, okay? And then you induce from there. Would be much higher inducibility, more reliable. Also, same time, you can confirm this is a reentry or focal tachycardia, so on. Now, ironically, many posterior fascicular VT patients, they undergo VT ablation. After ablation, no one developed posterior fascicular block. Have you seen it? After ablation? So how come? If it is a posterior fascicular VT, you're ablating that thing. That makes sense to you? Does not.
I'm sorry. I didn't understand you clearly.
If you have a posterior fascicular VT, you are bleeding close the posterior fascicle. Sometimes they ablate a bunch of time, not just one burn, bunch of
Yeah.
burns.
Yes.
Why don't they develop posterior fascicular block? You burned it.
Yeah.
Why not?
Yes.
What I mean, posterior fascicle is probably bystander, nothing got to tachycardia. I want you to read paper by Wong, W-O-N-G, as Mel Shyman's group in circoarrhythmia 2 years ago. They are proposing potential critical tachycardia P1 nature. It is a septal fascicle. Okay?
Okay.
Posterior anterior fascicle, upper septal fascicle, all those is a bystander. We think that the critical circuit is in the septal fascicles. Also important to remember, you've never seen septal fascicular block ECG. Have you seen it in your lifetime?
No.
No, why is that? That's something that you need to also ask yourself. You're a smart cookie. Why not? How come I don't see septal fascicular block in any patient in your lifetime? Simply because it's a network. It's not a one fiber. Okay?
Okay.
So you have to have a massive septal damage to have a septal fascicular block. Typically not consistent compared with the life. Usually the patient is dead.
Dr. Wang, can I ask a question?
Yes, sir.
So the delayed potential, mid-diastolic potential is a mechanical artifact you meant.
Yes, it is.
Then how does it differ from the real P1 potential? Could you please explain how to
Look
define?
at there's a nice example. Look at the LV signal 3-4. Is it that sharp, small fascicular potential? No,
Yeah.
fascicular potential. So yeah, that's it. That should look like that. Look at the compare size, the amplitude, the duration of your signal. How can the electrical fascicular potential can last that long? This is almost like 100 millisecond duration. It doesn't make any sense. Second, how about the component of a signal? They're far field, low amplitude. Maybe one sharp potential and R that I see as a local potential. Rest is all far field. P1 potential is almost like a Purkinje potential because it's another fascicle. Therefore, this is not consistent with the signal that I'm looking for. Okay, look at that potential small L3-4. Also in L1-2, there's a small potential comes and goes. You see it? Yeah, that is a typical conduction system recording.
Okay.
Okay, so it is important to memorize His bundle potential, normal sinus rhythm. That would be a landmark for the conduction system potential. So you guys need to keep looking signal, memorize those signal images. It's important. Short, very sharp, okay, and very high frequency content.
And after ablation, there is a big double potential. No, post ablation. Yeah. Previous one.
Go back. What?
So in LV 1 and 2, not this one, previous one.
What? Which one? Is
Post
referring?
ablation.
Have I missed it?
Yeah, this one.
This one is
Yes,
post
this one.
operation.
So
What
in
is it?
LV 1, 2, 3, 4,
Mm-hmm.
there's a big delay and double potential during
What is
mid-diastolic period.
what are you talking? LV 1, 2, 3, 4?
LV 1, 2, 3, 4.
That's a systolic diastolic heart have the bubble motion, my friend.
Okay. So
Opening and closing.
yeah, systolic mechanical artifact and
Yes,
diastolic
that's
mechanical.
correct. Yes,
It also shows the polarity reversal.
that's
Systolic
correct.
and diastolic.
Yes, you're perfectly right.
Interesting.
Yes.
Wow, this is a very unique EGM. Yeah, okay, we can see clearly.
So, yes, because you're close the valve apparatus. Now, I have one more recommendation for the people don't have a 3D. Please do LV angiogram, confirm where your catheter is, okay?
Okay.
That would explain a lot more things for you. You can figure it out yourself. You don't need to make me a bigger, comment business. No. So even 3D era, I know Dr. Park and Yonsei University team does a good job, and they do LV angio no matter what, whether you have a 3D ICE, they like to see things. I think that's a proper approach. That's a good recommended, especially 2D era countries, Mongolia, Cambodia, Myanmar. okay? And take LAO, RAO view, and geography, LV going. So that way you will know. And then I think your approach is correct also. You do one mapping catheter transaortic, second one transeptal, okay? That's a good way.
You teach us.
Yeah, so do review, please review the paper by, Mel Sherman's group. The last, the first author is Wong, Christopher Wong, W-O-N-G, is a circle arrhythmia. Okay?
Okay.
Dr. Saro,
Ah.
when you ablate the vascular VT, in which time do you approach it transaortic, which time transeptal? This case, you use transeptal approach, right?
Well, 100% I am going by the transeptal approaches because the Dr. Chauhan had told me that transeptal approach is much better than the transaortic. So for the mapping, I put in the transaortic, and for the ablation, I put the transeptal. I never tried the transaortic approach for the ablation.
Okay. So there's a threading, on the threading window, there's question. Can you show? Thanks for a nice presentation. I have a question. Is that the HV one-to-one correlation seen in vascular VT also frequently observed in papillomuscle VT? To whom are you asking, Dr. Kim Min?
Yeah, to Professor Han, please. Yeah, this patient showed the during VT HB interval reproducibility one-to-one correlation. So I think it is more favored to vascular VT. However, the QRS duration and configuration of ECG also favor to the papillary mobility, but I can't understand why this EGM shows always HV correlation one-to-one conduction.
It is not uncommon to young patients. You will have any form of a conduction system VT or papillary muscle VT. Papillary muscle also involve Purkinje fiber, remember? So therefore, retrograde conduction through the conduction system is going to be much faster than local conduction. So you will see His bundle preceding local QRS complex. Okay, you just mainly timing and also involvement of Purkinje network. So that's what the challenge of a papillary muscle versus a fascicular VT in young male patient, and EKG is so crucial. Surface ECG, okay? Your surface ECG first need to fit the criteria for fascicular VT. Start thinking fascicular VT. When the VT QRS complex wider, think twice. It's not a fascicular VT. Okay?
네, 감사합니다.
Thank you. And how
I think
about the
Dr. Pitch Manuel in San Francisco also ask a question to Dr. Saro. He's asking whether you try to entrainment pacing or resetting of BT in LB.
We did that already.
yeah, this one?
Okay.
I'm trying to show this is the entrainment from the left ventricular free fall side, and the entrainment was less than 30. Yeah, it had 397 somewhere. Yeah, it's 397. So
Okay.
we
Now-
had tried to entrainment.
Now this you need to be careful here because your output Saro
It's very high.
capturing both myocardium and the Purkinje vesicle.
Mm,
You see that?
yeah.
So for you to do this, you really need to put out the output all the way down, increase very slowly. When you start capturing, take a look at the whether conformation that to make sure that the local capture is only vesicle, not the local V. You can see your pacing does not match the QRS complex. Can you see that?
Yes.
Pace the complex versus the clinical VT, they're not same. So it's not a conceal. Okay? So
I
you
thought
did
it.
Yeah, so make sure that you take care that zero down the output and then make a look at it. The second important thing is that Dr. Kim Min asked that question about whether papillary muscle would have HV one-to-one. This would be the same as the papillary muscle pacing because you're pacing LV septum, LV muscle plus fascicle together.
Yeah,
So you
all the area all together. Yeah,
All the
that's it.
HV is exactly the same as during the tachycardia and during the pacing.
Mhm.
Yeah, but
Okay.
okay.
How
Doctor,
about
I have a practical question for you. So in Korea, we generally use a 3D mapping system for not only for the ischemic VT, but also this kind of idiopathic VT patients. But sometimes mapping catheter bump the tachycardia.
Yes.
And in the old paper from Hamburg group, they waited at least 2 hours to induce again. So in such cases, how to avoid this kind of bumping VT, or if we bump it, how to induce it?
Oh, that I don't know. That you ask $1 million question. Now, that's one of the reasons that you put a diagnostic catheter in LV, dodeca-decapolar catheter, close spaced, and make sure you have a reliable inducibility, and then you try to not to manipulate that catheter. Now, if you do both transaortic approach to catheter, likely you're going to do larger catheter, you're going to bump it, much higher incidence than transeptally you do approach it for the mapping and ablation. That's one of the reasons we prefer the transeptal mapping ablation and mapping the initial diagnostic catheter transaortic, and then we station there as much as possible. In other words, trying to minimize the motion or movement of the catheter there. Okay. Now, is there any trick for inducibility other than we know isoproterenol, rapid pacing, and so forth? But I have not found any other trick that once you bumped it, they're gonna come back. Now, pace mapping can help you. I think you can find a ballpark area, but I don't know whether that can confirm the diagnosis, especially in few cases, or at least in, I think, significant number of cases, more sort of a focal behavior than true re-entry. In Karl-Heinz Cook referred that to before. But those are making it completely different. Then your ablation would be way off. You don't know where it is. So I think once you prove that the re-entry mechanism, maybe you can, try to do sort of a kind of a empirical ablation using several methods suggested by the few investigators in the past, especially XW Cedars. He has some mathematical formula to figure out where is the potential circuit, but none of those are very specific. I think you could end up creating more lesion, especially when you're dealing with such young patient. I think my best approach is that to bring back, try to minimize the number of lesion instead of trying to put a lot of burn in there. Okay.
Okay.
And then I'm going to ask you one more. I'm going to add one more comment. Even though you may present with just one fascicular VT, many young patients may have more than one form. We found at least so far more than 3 patients had all 3, anterior, posterior, and mid. And then your ablation, even though pretty close to the same area, most of them are, but then you really need to know what you're doing, because high upper septal form, sometimes you map wrong, you end up causing heart block because you're too close to his bundle. Especially also anterior fascicular form as well. You just right up the left bundle, anterior fascicle, just a little bit off. It's not too far away from the main left bundle. So I do recommend that probably bring back for patient's sake. Okay.
Okay. And also I have to find out that the fascicular VT is commonly associated with the AV inertia. I found 2 patients.
Yes.
2 patients, and I looked for the paper, and Peng Sheng Chen's group had a paper about that one. Around the 20% of the fascicular VT patient had AV inertia associated.
Multi-center study shows that 18%.
18.
Okay. And then there is also coexisting simultaneous double tachycardia. There's a case published by Japanese group. Also, there's some other case reports that the patient has an AVNRT, suddenly switch to the fascicular VT and back and forth.
Yeah, and this is very difficult. This
Yes.
is very difficult.
Double tachycardia. So those are very rare form, but it's happened.
Yeah. So and how about the first question from the Professor Park?
Which one?
Why in Southeast Asia the fascicular VT is very high?
Okay.
I also read from the papers, and the American doctors also tried to comment on that one, but still I'm not convinced enough.
Well, we are looking at right now, and unfortunately, we are trying to do project in Myanmar because we have a so high instance of vesicular VT in Myanmar. And we are looking at whether there's any genetic difference of the calcium channel handling, like SR2, renin receptor abnormality or things like that, like a CPVT. But that's only hypothesis. But certainly other, comment, feedback from Japanese guys, Dr. Park also know that maybe has to do with the food that it tastes too spicy. But as far as I know, Mongolian doesn't eat too spicy. So I think that does not really explain to me. I think it maybe has to, we are dealing with the different ethnicity and possible genetic background. Okay?
Last year, I had chance to discuss with the BT specialist Nogami and Kyoko Soejima and also Mark Schlinsky. And they mentioned, they discussed about why there's a high prevalence of vascular VT in India and Southeast Asia. And one of potential hypotheses is inflammation. The subclinical myocarditis make a scar because the Purkinje network spread all of the endocardium, but but I don't know why it prefer the post-receptor side. But it is one of hypothesis: genetic, inflammation, and the environment, including food. So probably the young EP doctor should prove it.
Inflammation from what?
Inflammation
From what?
subclinical myocarditis.
But if that hypothesis is correct, Dr. Park, inflammation process in general, they affect more mid-myocardium and epicardium,
Right.
not endocardium. So that is very, very unlikely. Because if cardiomyopathy, inflammatory cardiomyopathy, when they manifest, by the time they involve endocardium, typical manifestations of VF arrest. That's what I learned in the school many years ago. Because we
Maybe
have a lot of things to do.
likewise rheumatic inflammation.
Yeah, so I think it is has to be very specific. Purkinje, maybe network associated inflammation, something like that may explain, but not in general inflammation. No, that wouldn't explain.
So all those are just hypotheses.
Right. None of us know yet. Hopefully we get excited to do a study a little bit.
Okay. So we had a good discussion and enjoyed a nice presentation for 1 hour. Any other question or comments? Oh, one more comment from Dr. Kim Min. Please speak by yourself.
네, 죄송합니다. Recently, I have experienced non-compaction cardiomyopathy in two patients with vascular VT undergoing ablation, and I'm going close follow. So I think it is made possible that this difference in the epidemiology difference of cardiomyopathy may also have this vascular VT influence.
The vesicular VT initially described in structural heart disease patient in general. Then I think Jibes and other people describe it in idiopathic form. But if you have a structural heart disease, certainly you're more subject to have a bundle branch reentry and vesicular reentry and so forth. So those are clearly reentry mechanism, most of them involved. But I think in new patients, especially young, healthy patients, otherwise we cannot prevent at this point. I think it's probably mixed bag. I don't think it's just one form. Because of if you put your diagnostic catheter in posterior fascicle, beautiful potential, you try to entrain your area that can entrain is very, very small, almost behaving like an exit site. Second is that even your pace mapping, you're sometimes never able to reproduce a perfect match. They say 96%, 95%, and so on, but it's not 100%. So I think maybe posterior fascicle is not per se, is not involved with the tachycardia, it's a bystander. I think just exit site probably, but a critical circuit is a little bit more subtle aspect for your blade usually. That's what we learned so far.
Yeah, I don't have an answer to Dr. Kim Min's question, but if you have a chance, please look for the ESC heart failure guidelines regarding the non-dilated hypokinetic cardiomyopathy. And the non-compaction is one of the important disease category, and most of them are related to genetic background. Okay, so thank you very much, Dr. Saru and Dr. Huang. We had a
Thank
very
you.
good discussion.
Enjoyed very much.
Thank you.
Next international EGM conference will be May 31st, Saturday, 9:00 a.m. Same time. Probably next turn will be Myanmar. Am I right?
No, Korea.
Korea?
Korea. What I received the information from Professor Kim, Taewon Kim, I think is Korea and Myanmar.
Korea
Check.
first. Okay. So
Am I
Korea
wrong or right?
will prepare next time, May 31st. Okay, thank you very much, everybody, and have a nice weekend. Bye.
Okay, take care, everybody.
Thank you.
Thank you.